Good morning, everyone. Thank you for the kind invitation to speak at this really impressive symposium. My topic today is the current state of MRI-based radiomics of pediatric brain tumors. My name is Dr. Sanjay Prabhu. I am a pediatric neuroradiologist at Boston Children's Hospital and the medical director of imaging informatics. In today's talk, I'll be covering the following topics. What is radiomics and radiogenomics? Why should we care about this and why now? The state of pediatric brain tumor radiomics today with some examples. So limitations of this area of research and further developments in the area. So let's talk about what is radiomics and radiogenomics. It's a fairly basic discussion, so we get into the meat of the matter as we go along. So what is radiomics? Radiomics is an extraction of handcrafted features from routine imaging studies that quantitatively captures the textural and morphological characteristics of a given tumor. You try and extract quantitative features which are beyond the level of human perception. So here you have a set of imaging studies with MRI plus contrast. Here's the tumor. You segment the tumor and the surrounding areas of abnormality and create these regions of interest or ROIs. And then if you extract some features from those, which we will talk about, like the shape, the histogram, textures, etc., and then you analyze these features and using deep feature extraction, and you can use pre-trained convolutional neural networks, for example, and then correlate them with genetic expression or the survival, etc. So radiomics is the extraction of large number of quantitative features from complex clinical imaging arrays. You transform these images now into high-dimensional data, and this is now subsequently mined to correlate with histological features, underlying genetic mutations, and malignant potential. You correlate these features with the grade, progression, therapeutic effect, or overall survival. Radiogenomics, on the other hand, is correlation between the gene expression and radiomic features. So it's the next stage in the process here. The hypothesis being, if you have dissimilar phenotypes of regions of ROI, so once you have done region of interest in a tumor, dissimilarities in the phenotypes is attributable to gene expression features. That is the basis of radiogenomics. In another way, looking at it as genetic changes with phenotypic consequences is reflected in variations of radiomic features. So if you have a tumor which looks different in certain areas, that is a result of some kind of genetic variation and vice versa. A typical radiomics workflow includes starting from imaging, segmentation, feature extraction, machine learning, and validation. So you have to go through this whole process in every case, every tumor or every lesion that you take up for radiomics research. Segmentation involves separating the tumor and the surrounding abnormality from other tissues. It's a series of algorithms to delineate regions of interest which will form the basis for further steps in the radiomics workflow. You separate the lesion, and this is a very key step between image processing and quantitative analysis, and when done well, this can prove a basis for good studies. When done badly, it can affect your subsequent research, however well you do the subsequent steps. Feature extraction is the use of existing features to calculate a feature set with higher degree of abstraction. It refers to algorithms for calculating a certain feature, and these extracted features then go through feature selection, and these top features are integrated with clinical and pathological results, and these features are then input into machine learning methods to build prediction or classification models. Quantitative features exhibit different levels of complexity and express properties of things like lesion shape, the voxel intensity histogram, and secondarily of the spatial arrangement of the intensity values at the voxel level. These are extracted either directly from the images or after applying different filters or transforms. The various subgroups of quantitative features, including the shape features, which describe obviously the shape of the traced regions of interest, and its geometric properties such as volume, maximum diameter along different orthogonal directions, maximum surface, the tumor compactness, and the spherical nature of the shape. For example, the surface to volume ratio of speculated tumors will show higher values than that of tumors of similar volume. First order statistics describe the distribution of individual voxel values without concern for spatial relationships. These are histogram properties reporting the mean, the median, the maximum, minimum values of voxel intensities in an image, as well as the skewness, which is asymmetry, the kurtosis, which is the flatness of the lesion, uniformity, and the randomness or an entropy. Second order statistics are more like textural features, and these are obtained by calculating the statistical interrelationships between predetermined distance along a fixed direction of the what's called the gray run length matrix, or the GLRM, and quantifying consecutive voxels with a similar intensity along fixed directions. And then you have higher order statistic features, which are obtained by statistical methods by applying filters or mathematical transforms to images. For example, if you're trying to identify repetitive or repeating or non-repetitive patterns, suppressing noise, or highlighting certain details. These are in another area. For examples would be fractal analysis or Laplacian transforms of Gaussian filtered images, which can extract areas with increasingly coarse structural patterns. So this is just a very brief introduction to the area of radiomics. So the more important question is, why should we care, and why should we care now? Basically, there are potential applications of radiomics, right? You can identify primary tumors, you can differentiate different kinds of tumors. For example, I'll give an example of an ATRT from a medulloblastoma or medulloblastoma of ependymoma, and you can do this better than you can do with just the human eye. You can also refine differential diagnosis, you can grade tumors, you can evaluate mutation status and predict treatment response, and you can identify recurrence. The next question is, why should we care now? What makes it more relevant for our times today? As you all know, there's a changing landscape of brain tumor classification. The latest classification of the WHO just came out a couple of months back, and this again stresses the integrated diagnosis, layered reports, and the matrix approach to integrated diagnosis. So what does this mean? This means that brain tumors are now classified into specific types and subtypes. They are graded to grades 1 and 4, like we always used to do. Histological features still relevant, which includes phototic activity, anaplastic nuclear features, microvascular proliferation, necrosis, and then you have molecular profiling, which is now a key feature. So in addition to histological staining, which we've always done, we also have a very detailed pathological diagnosis pathway, which now includes things like methylome profiling, next generation sequencing, and whole genome sequencing. This helps you to arrive at a more accurate diagnosis and classify the tumor based on the 2021 classification of the WHO. So the layered report structure includes integrated diagnosis. This includes histological diagnosis, the grade of the tumor, and the molecular information, where histology refers to what type of cell does this tumor resemble. That's the first question. Question 2 is, how do the cells look and behave? So nuclear atypia, mitosis, microvascular proliferation, necrosis, and then finally the molecular typing, for example, IDH mutation or the BRAF status, etc. So basically all tumors now have this kind of layered report structure. challenges that's been posed to the WHO classification is that it is costly to get genetic analysis done. There's always some delay in getting molecular diagnosis confirmed, especially in some parts of the world where it's hard to access this kind of genetic analysis. And there's also variability in histological and molecular diagnosis. So you get different specialists who come up with different interpretations of the same genetic profile, and there's limited subspecialist expertise. So certain centers have more expertise than throughout the world. So radiomics and radiogenomics, I believe, has a potential role to play in mitigating some of these challenges. So let's talk about the pediatric brain tumor radiomics today. Give you 3 examples to show you why this is important. Some specific examples here would include medulloblastoma. It's a heterogeneous disease. There are 4 molecular subgroups. We have the wingless sonic hedgehog, the group 3 and group 4, and they have distinct developmental origins, unique transcriptional profiles, diverse phenotypes, and varying clinical outcomes. And you have to correlate these non-invasive imaging features like radiophenotypes and genomic data and molecular markers to come up with a good radiomics-based profiling of these tumors. So this has been done in lots of studies in the recent years, and some of these features are things like lateralized cellular location for the sonic hedgehog subgroup, CP angle location for the Wnt subgroup, inferior location with dilatation of superior recess for fourth ventricle for group 4 tumors, minimal enhancement of the primary tumor and epidermal metastases with mismatching pattern as a specific feature for group 4 medulloblastomas, and then profiles based on spectroscopy try to differentiate sonic hedgehog from non-Wnt and non-sonic hedgehog medulloblastomas. And then other nomograms have been established to try and predict which kind of tumors are sonic hedgehog type subgroups. These are not specific because I've tried to apply these in practice, and this does not always come out to be, always true. But this gives you a guideline. But you still have to have tissue biopsy at the end to confirm these. We are still not at the point where we can just rely on this for diagnostic purposes. So here's an example of a tumor in a 6-year-old child who came in with this tumor in the posterior fossa. This is a medulloblastoma. It's a midline location. It is fairly homogeneous looking hypointense, T2 hypointense mass in the midline involving the vermis in the fourth ventricle. And there's no significant, you notice there's no peritumoral edema. It's diffusion restricted, and there's a fairly solid looking tumor. You don't see too many peritumoral cysts or any macrocysts. Enhancement is a little patchy. You see some areas of enhancement, some areas of non-enhancement as well. And then you have leptomeningeal metastases in the cerebellar folia here. So if you use the radiogenomics chart here, this is group 3 medulloblastoma based on the midline location. It is abuts the dorsal brainstem, has this kind of a fluffy looking enhancement, some patchy looking areas here. T2 weighted images usually are hypointense and homogeneous, which it is. There's no edema, which again, this is a specific feature of group 3s, and also Wnt can have a similar one as well. But notice that group 4, group 3, and Wnt can all have very similar looking, similarly will have less peritumoral edema. And then your intratumoral hemorrhage is absent, which is only seen usually in the Wnt types. So this kind of fits with this profile, right? Although you don't actually have much hydrocephalus, we did not have spinal metastasis in this case, and there was no peritumoral cyst. So not all the features fit, but it's more likely than not that this is a group 3 medulloblastoma. So next we go on to just look at the different subgroups and how clearly they fit. And you can see that if you just look at them with the human eye, it can be difficult to differentiate the features, which is why radiomics comes in, because it can extract features that you cannot typically see with the human eye and put together. But you still do the same things that you do now, but you might use radiogenomics as a extra additional layer to refine a diagnosis. The other area this has been used is to differentiate ATRT from medulloblastomas. So ATRTs and medulloblastomas have similar imaging and histological features, but different outcomes. And in this study by Dr. Yom from Stanford, they extracted some 1,800 features of these tumors and then reduced them to have multiple features to reduce them to 3 to 4, and they found that these three top features here are voxel intensity at the 90th percentile, inverse difference moment normalized, which is one of the second order features, kurtosis, which is the flatness of the tumor, and these are all derived from the T2 weighted images. So basically you can use a T2 weighted image to try and differentiate ATRT from medulloblastomas. And most importantly, they found that how brightly or faintly a tumor enhanced was not a distinguishing feature between these two tumors, which is contrary to what many of us think if you do it with a human eye. The other area where this is all radiogenomics has also been used is to in the ATRT subgrouping, and we're currently doing a study right now on this. ATRT is atypical territorial drive-by tumor. It's a tumor that occurs in young children. It has a very poor prognosis. We have the largest number of survivors of ATRT in Boston, but we still are no closer to getting a good diagnostic pathway to identify different subgroups, and also the treatment is still being worked out. Basically, in ATRT, there's recurrent genetic alterations of the SMARCB1, or rather the SMARCA4, but on a genetic level, they're very heterogeneous. And a study from this group in Germany has come up with these three molecular subgroups: the subsonic hedgehog type, the tyrosine type, and the MYC type. And these have distinct genotypic, chromatin, and functional landscapes. And knowing the MRI surrogates for these subgroups might contribute to risk assessment and individual stratification within frameworks of radiogenomics. So we're currently looking at some kind of radiogenomic markers for ATRT. So we talked about some examples here of how you can differentiate different tumors from each other, like ATRT medulloblastoma. The subgroups of medulloblastoma are tumors where we don't actually have much of a diagnostic pathway to separate the different tumors and try to develop treatments based on those, like an ATRT. What are the limitations? So the limitations of the radiomics or radiogenomics primarily is standardization. Standardization is the basis of robustness, reproducibility, and generalizability. Current standards lack results validation. There are incomplete results reports and unidentified confounding variables in the source database, especially for retrospective data. There have been evaluation systems which have been proposed, comprising of weighted metrics to determine the workflow completeness, the model quality, and clinical adaptation potentiality of radiomics studies, something called radiomics quality scores, or RQS. And these are going some way to standardize this area of research. Another important area where you have limitations is reproducible segmentation, and this can be challenging for things like brain tumors, where the edges of the lesions may not be as clearly visible as, say, a lesion elsewhere, different other types of lesions in the body. The MR images that we often receive from institutions often lack technical parameters like scanner strength, voxel size, which can also make a difference, and the repeatability and reproducibility of results can be challenging. So what are the further developments in this area? So the further developments would include, the dream would be to have large numbers of features extracted from numerous pathologically confirmed patients and develop this large-scale database of tumor classification. And basically deep learning over time can help to build more sophisticated classifiers and help discover new correlations between imaging features and gene expression. It really requires multi-institutional collaboration and open availability of source code and data, and this will allow us to develop these big databases and hopefully help our young patients. Radiomics, I believe, will also accelerate development of histopathology because segmentation and radiogenomics can suggest the best area to biopsy a lesion. So in summary, we have gone through the following areas. What is radiomics and radiogenomics? Why should we care about this and why now? Some examples of how radiomics is being used in brain tumor research today, some limitations of this area, and further developments. Thank you very much for the opportunity to speak to all of you today.